Good morning, Suprabhat. Welcome to CSI 2018, the 70th Annual Congress of the Cardiological Society of India. We truly are big brother. We are big brother to USA. Cardiological Society of India is 1 year older than the American College of Cardiology. CSI was established in 1948, ACC in 1949. Welcome all of you. Now I'm going to help you to navigate through this wonderful arena which we have created in the MMRDA grounds BKC. Let me get you through the entire area. All right, once you enter the venue, first is the registration desk. In the registration desk, you have quick registration get done. They are all automated in a manner that you are likely to get your badges within 10 seconds. Once you move further down is the central selfie point, or the arena which we call it, the main atrium, and here you can see Dr. B.C. Roy's statue. As we go on to the left side of the central atrium is the scientific arena. So this is where all the academic sessions are happening, and the time has come. The sessions would start in a couple of minutes. We would wish that everybody get into the auditorium as quickly as possible. On the right side are the two main halls. On the far end is the hall A, and immediately as you enter on the right is hall B. So the right side of the wall panel, if you see, shows you the world history of cardiology, and you have across the timeline different landmarks in cardiology set by people all over the world. This is the walkway through the auditoriums on the right and through the left. You have a comfortable seating area. The hall A is to the far end on the right side. And just when the hall A ends, that is the area where you have to use your restrooms and emergency exit. Our CSI TV is coming up, and we'll have live feeds of the entire proceedings which we run through the studio. So we have interesting conversations lined up. So on the left side is the hall C, and subsequently we move forward towards the central atrium. Will come up the hall D. So today, the CME day, hall A, B, C and D are all functional, and the session starts at 9 a.m. I hope everyone is in the auditorium. You have a LED screen in front of the auditorium to give you a quick peek as to what's happening. Then when we move forward, we have our CSI TV, the faculty lounge and the preview room. For the faculty, we request them to load their presentations well in time, and we have a comfortable faculty lounge also besides. Then we move out of the scientific arena once again, and once you are out in the scientific arena into the main atrium where our selfie point and important statues of Dr. B.C. Roy, Dr. K.K. Date and Dr. P.K. Sen is there. Going further on the right side would be the trade area and the food area. So in the trade area, we have more than 75 exhibits. As soon as you enter the trade area, on the right side, I would like you to recognize Meet the Expert Lounge. We have created a new format wherein you will have experts spending an hour with you so as to have a one-to-one interaction and solve all your doubts. You have interesting cases, interesting CDs, show it to them, present it to them, and they'll be very helpful to guide you through those difficult situations. If you move on to slowly on the left side of the trade area, in the left side of the trade area, we're going to have a CPR workshop. So this CPR workshop is essentially designed to train you in cardiac resuscitation of a sudden cardiac arrest victim. We're going to run the CPR workshop from tomorrow, from Friday and Saturday. Friday morning 10 to 12, 1-hour sessions, 2 to 4 in the afternoon. Same thing on Saturday. We recommend that you pre-register yourself for the CPR workshop. And the CPR workshop is essentially designed. It's a workshop for lay people, a basic CPR course. And because it's a basic CPR course, we'll encourage the spouses of the delegates, everybody in the trade area, all those who are paramedics or non-medics, they are the ones who should make the use of the CPR area, where we will, once you complete a course, a short 1-hour course, once you complete the course, we'll give you a certificate also and a small I-card which states that I am trained in basic CPR. And moving further towards the right would be the food area. So we have no official lunch breaks or tea breaks. The lunch would be served from 12 to 3. You're free to visit that area any point in time, and the tea would be served through the day, in the morning and in the afternoon. So I've helped you navigate through the CSI TV completely, and what is more important now is that let me give you a brief glimpse of what's going to happen today. Today being the CME day, continuing medical education, Hall A is going to run CME in cardiology. Hall B is the National Interventional Council. All the interventions, catheterization, difficult cases is going to be shown there. Hall C in the first half, 9 to 1, is going to run the pediatric cardiology, and in the afternoon, 1 to 6, is going to be the electrophysiology and arrhythmia management. Hall D is imaging. Echo and imaging will run on that day. In the end, in Hall B, also we have a joint symposium between ESC and at CSI. So 6 to 7, ESC at CSI in Hall B. I would request that all of you are attending the CME. At the end of the day, you are going to get credit points. Maharashtra Medical Council has awarded 2 credit points for this CME day. So at the end of the day, you can sign that you have attended this course, and you will get a certificate crediting you with 2 CME hours. Let me give you a brief glimpse also on the important sessions or talks that are going to happen in every hall. Hall A, let's look what's going to be interesting, what I would like to attend, what I would like you to listen to. Hypertension is a major problem. Now we have guidelines coming from across the Atlantic, from the US, from the Europe, ACC guidelines, ESC guidelines. It's always conflicting, confusing, and Dr. C.S. Venkatram is going to help us to decipher what is best in the Indian context. So be there. Also, Dr. Prakash Didwania is going to tell us the contemporary management of heart failure in one of the important sessions. Dr. Jagat Narula is going to tell us about peripheral artery disease. It's very important how to recognize what is the current management strategies in this. And in the end, there is a good session in Hall A where we are going to have the experts speak. You have Hubert Segevis talking about the management of hypertrophic cardiomyopathy. You have Dr. Shripal Bangalore talking about cardiovascular diseases and chronic kidney diseases. And finally, you have Dr. Navin Nanda speaking about echo in mitral regurgitation. What is the utility? What's in store in Hall B? Hall B, the National Interventional Council running it, and you have most practical sessions here. You can meet the experts. There are sessions which are designed where you will have nightmares in cath lab deciphered properly. You have a CTO workshop going on, and interesting cases presented through the day. So Hall B is all for the interventionist. Hall C, pediatric. It is the pediatric and the echo arrhythmia sessions in the evening is essentially designed for the cardiologist. So this is not going to be very, very hardcore pediatric cardiology or electrophysiology, but it is for the cardiologist, a nice program devised by Dr. Goswami and his team. For example, in pediatrics, you have how do you take vascular access in infants? You have a session on that. What are the common mistakes done on echocardiogram? Similarly, in the arrhythmia session, you have complete basics on how to tease out on the ECG maximum information, how to handle devices, what are the controversies in arrhythmia management. And yes, finally we have Hall D. Hall D is on imaging. The Imaging Council has done a remarkable job. We have not only echo, which talks about 3D echo, stress imaging, but we have important sessions on CT scan, the role of cardiac MR. These things are getting more and more relevant today, and it is important for the clinicians to update themselves. What is the niche value of each of them? In the end, you have speak with the masters. So Navin Nanda, Martin Maron, Richard Chazelle, they are going to help us how to use the imaging as well. So eventually, we will have this entire CME day packed from 9 to 6. What is more important is whenever you have time, don't miss on the CSI TV. Through your app, you can log in and you can witness what's happening in the CSI TV studio. Now, the concept of CSI TV studio is this, that we have many of these international and national faculties giving their talks, but the talk time is often limited, and therefore there are certain important take-home messages which we require to be threadbare discussed. So the format the CSI TV studio is going to offer is, there's going to be an expert faculty, but there's going to be an expert interviewer. He is going to interview him and bring out the best take-home messages. So let me give you a highlight of what's happening today. It's packed from 10:30 to 6 p.m. But one of the few important ones which I'll highlight is Dr. Ajit Mulasari has done a great job of managing STEMI patients in Tamil Nadu. Dr. Dhiman Kali is the STEMI Council Chief of the CSI. There is going to be an interaction, a guftagu between the two, how we can implement the knowledge one has gained from the STEMI management in Tamil Nadu to the rest of the country. We'll get important insights. The legend, Dr. Navin Nanda. And we have a tete-a-tete with Dr. Navin Nanda by none other than Dr. Robin Pinto, who's himself accomplished clinician, cardiologist, and an echocardiographer. So you're going to have a good session on with Dr. Navin Nanda through the day. We have also tried to create some kind of a panel. So there's going to be a panel discussion, and don't miss out on this. Dr. Kane is going to interview two of the important international faculty, Ramesh Dagubatti and Dr. Vijay Iyer. And this panel is going to revolve around complex PCI, how to navigate through them, and also how to handle chronic total occlusions. One of the important sessions in the CSI TV today is going to be on the talent trial. The talent trial tells us about the status of the Indian stents in the world context, and you have none other than Dr. Upendra Kaul, Dr. Ashok Sheth being questioned by international famed Samin Sharma. In the end, we are going to have a wrap-up. A wrap-up will be done by none other than my old friend, Dr. Ronnie Matthew. We have grown together. When both of us had complete black hair, and now we're both grayed. So Ronnie is going to give you a wrap-up from Hall A, the important CME sessions in general cardiology happening through the day, and we'll finish at that time. So I would encourage you that all of you, please download the CSI app. The CSI app is going to run live sessions, live relay of sessions from all the halls. So it's important that if you are in Hall A and you want to see what's happening in Hall B, or if you are in the lunch area, food area, anywhere, the Wi-Fi is free. Jio has provided a 4G Wi-Fi to you. You log in through this Wi-Fi from the app, get into the e-resource, and you have CSI Live and CSI TV both. Get into the CSI Live and you have different halls which will show what are the live proceedings going on in this hall. So this is something which we would like you to make use of, so that you have a complete platter on your mobile handset. And that's where the digital surprise is there for you. So once you have registered, all registered delegates, please see to it that you also get your digital surprise. That is the Lenovo tab. So as you enter in the atrium from the central selfie point, if you go forward, you would have the distribution of the Lenovo tabs happening there. So make use of these tabs, make use of your handsets, and get into the live relay of the entire session. All right, let me sum up. This is the scientific program happening through the day from 9 to 6, but we have important things lined up later on the day. 7 p.m. onwards, we have the inauguration ceremony. The inauguration ceremony is going to happen in Hall A. I would request all of you from 6 to 7, stretch yourself, move around, but be in Hall A right from the beginning. 7 p.m. sharp, the inauguration begins. The highlight of the inauguration is going to be that Mr. Ajoy Mehta, the Municipal Commissioner of Greater Mumbai, is going to inaugurate officially the CSI 2018. We have Lifetime Achievement Awardees. We have Dr. Savitri Srivastav and Dr. Ashwin Mehta receive the Lifetime Award. By 8 p.m., we finish the official function. 8 to 9, enjoy the cultural offering which Maharashtra has to give you. There are important dance and music programs, 8 to 9 p.m. And in the end, we all move towards the food court area where dinner will be served. Wish you a very happy CME day. Thank you.
I'm an interventional cardiologist from the University at Buffalo in Buffalo, New York. It is my pleasure to be at CSI 2018 in Mumbai. This is my hometown, and it's a pleasure to be back. I will be presenting a couple of talks here on high-risk primary protected interventions as well as percutaneous left ventricular assist devices. The focus of my talks is really on identifying these patients and evolving strategies in the management of these patients. In terms of the percutaneous left ventricular assist devices, I think it's more an introduction to all the newer technologies that are available right now. The main messages here from my talk on protected PCIs and high-risk PCIs is really understanding the anatomy. It is about making sure that you identify the high-risk patients and come up with strategies in managing these patients. When it comes to the percutaneous left ventricular assist devices, I think it is important to understand the myriad of devices that are either already available or will be available soon, their roles in cardiogenic shock, and the appropriate device for the appropriate patient. Thank you.
Hello, dear friends. Welcome one and all to 70th Annual Conference of CSI at Mumbai. Hope all of you are enjoying the wonderful arrangements made by the organizing committee, and hope to have a good academic feast in the coming 3 years at Mumbai. I, on behalf of CSI NIC, welcome you all to this NIC sessions in Hall B today. And all the sessions are being planned to cover the basics to advances and coming to all the future developments which are likely to happen in interventional cardiology. I would like to stress upon once again to all our colleagues that the primary PCI is so important that it saves lives, and it has to be done right to these patients who are needing it. And then in countries like India, wherever the cath lab facilities are not available, probably we can also take the help of advantage of technology, having ECG transmitted to one of your nearest cardiology colleagues and confirm it, and take the benefit of pharmacoinvasive strategy and give drugs like tenecteplase and others, and then shift the patients to nearby center with PCI facilities. This sort of approach is again quite suitable for our country and very appropriate where there is disparity in the existing setup of cath labs. In our NIC data, we knew that still significant number of patients do get benefit by pharmacoinvasive strategy. So time is very important. Without losing time and then damage to myocardium, the cardiology colleagues should give the benefit of pharmacoinvasive strategy in the periphery to these needy patients. One other very important advice I would like to give to all our interventional cardiology colleagues on behalf of NIC is basically whenever a patients of Esther era, which were all going for CABG before, many of them with the advent of better quality of stents can be tackled by percutaneous procedures. So what I wish is don't go by semantics of vessels, but go whether complete revascularization should be possible in all the patients, in all the lesions. It's not the question of having multi-vessel disease, triple vessel, double vessel disease or single vessel any longer. The idea should be to have a complete revascularization in a patient. So what I wish to patients and all the cardiologists in periphery too is to have a second opinion on patients who are being sent for surgery. Most of the procedures which are being done by surgery before could be tackled percutaneously in today's era with the availability of better quality of technology and better quality stents. Another one important thing which is happening, which is upcoming in our Indian subcontinent is the advent of newer devices, structural heart interventions. We have now TAVR valves approved in our country, and then Merrill MyValve was also is about to get launched in our country. So all those patients, subgroup of patients who are going for surgery before could also get this benefit of getting this therapy in a less invasive way. And before I conclude again, I always would like to stress that not only interventions, the CAD is increasing leaps and bounds in our country, be it genetic, be it environmental influences. Prevention is always important. All of us who have especially family history should get ourselves checked, evaluated, and then probably take the benefit of statins and other preventive therapy like yoga, meditation, and following healthy food styles to prevent this rising epidemic of coronary artery disease. With this, again, I would like to mention that the coming National CSI Interventional Council would be held at Lucknow from April 5th to 7th. So enjoy the Lucknow hospitality, and it will be done by Sanjay Gandhi Postgraduate Institute of Medical Sciences people. Welcome one and all. Please block your dates of April 1st weekend and join us again at the NIC sessions in the coming year. Thank you, and welcome again one and all to this year's CSI.
Hello. On behalf of Cardiological Society of India, I welcome you all to Amchi, Mumbai for CSI 2018. The whole arrangement, both at the organizational level as well as the scientific level, under the leadership of Dr. Praful Kerkar as the organizing secretary, as well as Professor K.C. Goswami, scientific committee chairman, have done excellent job in this conference. The ambience has been fantastic. The participation has already started at a fabulous level with the increasing number of footfalls everywhere in all the halls. And I find enthusiasm amongst everyone, especially who are interested in cardiovascular science. So for the scientific part is concerned, Professor Goswami has incorporated the activities of different halls with the subspecialty councils like NIC, imaging, echocardiography, EP, and pediatric cardiology. So all the chapters have been covered in a fantastic way. And so for the organizational part is concerned, Praful Kerkar has done excellent job, especially in a makeshift arrangement like this in a open area. Really, I congratulate both of them. Welcome once again to Amchi, Mumbai, and enjoy the hospitality as well as the ambience of Mumbai. Thank you very much.
I'm Dr. Harshvardhan from New Delhi. It's really a pleasure for me to have come to attend this 70th conference of the Cardiology Society of India. A wonderful arrangement and a very well laid out scientific program. I'll be speaking on the subject of optimal medical therapy of patients with coronary artery disease. The patients of coronary artery disease not only require relief of symptoms, but they require medication to control the risk factor as well as to prevent the events like myocardial infarction and death. So our therapy for treating patients of angina not just be to give anti-ischemic treatment to control the symptom, but to give a comprehensive treatment so that the events like myocardial infarction and death can be prevented. Thank you very much.
Good morning, everyone. My warm welcome to all of you, specifically the delegates attending the CSI 2018, the national faculty, the international faculty, the industry who helped us organize this meeting, and everyone involved in the organization. Cardiology as a specialty has grown by leaps and bounds. Probably it's not an exaggeration to say that cardiology as a specialty is one of the busiest in terms of research and advances for patient care. Whether you call it TAVR or PCSK9 inhibitor therapy or LM interventions, every area of cardiology has seen great advances in the last decade or so. It is important for all of us to keep ourselves abreast of this knowledge, and I have no doubt that CSI 2018 will help us improve our knowledge and skills in a great way. My special congratulations to Dr. Goswami, the President-elect and Chairman of the Scientific Committee, his colleagues, Dr. Rakesh Yadav, Dr. Nitish Nayak, and Dr. Ramakrishnan from All India Institute, who have designed this scientific program to help one and all. My special congratulations to Praful Kerkar, Amit Vora, Dr. Satyavan Sharma, and Charan Lanjewar, who have really put in great effort in organizing this conference. Thank you very much.
Good morning. I'm Dr. Robin Pinto, cardiologist, Mumbai, and welcome to CSI TV 2018, a new initiative of CSI 2018. It is my honor and proud privilege to introduce and chat with Professor Nanda, supreme echocardiographer. Dr. Nanda needs no introduction to all of us, being a world-renowned figure, and has been responsible for popularizing this field even in India. Throughout his illustrious career, he has received numerous awards, accolades, and recently the Lifetime Achievement Award from the American Society of Echocardiography, the first Indian to receive such an award. He has innumerable publications to his name and authored many textbooks, some of which we had to refer to pass our exams. He is currently Distinguished Professor of Medicine and Cardiovascular Disease at the University of Alabama, Birmingham. Good morning, Professor Nanda. Welcome to Mumbai.
Good morning.
How is it to be back in the city of Mumbai, the financial capital?
Well, it's great to be back to the home city, kind of my home city for a long time. But before I go into that, let me just say that I know Dr. Robin Pinto since he was a child because his father was my mentor, Dr. Ivan Pinto, the great guy, very kind, very hospitable cardiologist. And every now and then he will take us to his home. And at that time I met Robin, who was a small child at that time. So it goes a long way. And I'm so very glad to be interviewed by none other than his son, who is himself a very illustrious cardiologist in Mumbai. So it's really great to be back in Mumbai here. As you know, it's like a homecoming to me.
Professor Nanda, after your formative years in cardiology, you moved on to London and then to University of Rochester, upstate New York. Where did you first fall in love with the subject of echocardiography?
Well, while I was in England, actually, I got introduced to echocardiography, where they were using it mainly to check for pericardial effusion. And then when I went to Birmingham, they were also looking at the mitral valve, aortic valve, and tricuspid valves. At that time, the pulmonary valve was thought that it could not be detected by echocardiography. So that was a problem at that time. But when I was looking at some autopsies and discussing with the pathologist, it was very clear that most of the pulmonary valve is not under the lung, and therefore it can be imaged by echocardiography, and especially if the pulmonary artery is even slightly dilated, it will be very easy to echo. So I went and actually with my mentor also, we went and actually did some patient examinations, thought that we could find the pulmonary valve, got that validated in the cardiac catheterization laboratory using contrast echocardiography, where at that time we were using actually indocyan and green. And so then once we could see all the 4 valves, pediatric echocardiography was actually born, or actually took off, because we could diagnose some congenital complicated conditions like dextrotransposition of the great vessels. I thought it was something very great for me because these were kids who were blue kids, they were cyanotic kids, and most of them would die because diagnosis could not be made very easily of transposition of great vessels. So once we could do that non-invasively and make the diagnosis, then in the cardiac catheterization laboratory, the atrial septum could be enlarged, the PFO could be enlarged for better mixing, and therefore these kids survived. And then later on, of course, they had surgery, a corrective surgery for transposition of great vessels. So that was something I thought was really very good, and I got very interested in the subject. And at that point in time, I was planning to come back to Mumbai, but everyone told me to stay there because they wanted to learn from me the technique of pulmonary valve detection, and even people from Mayo Clinic came down to my laboratory to learn how to actually examine the pulmonary valve. And so that actually, that's how I permanently stayed in the United States, although that was not my intention in the beginning.
So Professor Nanda, you've seen it all. M mode, advent of 2D, spectral Doppler, color, 3D speckle. In your opinion, what was the most seminal moment for you? What you think really changed echocardiography to make it such a burgeoning field?
Well, I think first of all, I think the discovery that we could see all the four valves of the heart, including the pulmonary valve, was a very defining moment, because that's how pediatric echocardiography took birth. Actually, it was there before, but that's how it progressed. And then, of course, another defining moment came when real-time two-dimensional echocardiography was introduced. And at that time, actually, after just a few years, there was hardly any echo laboratory anywhere in the world worth its name which did not have, or any cardiology department worth its name, did not have an echocardiographic equipment. Then actually the other defining moment came when color Doppler was introduced. And actually color Doppler was introduced by me in the United States, in Birmingham. And it's a very interesting story. What happened was that I'd gone to give ground rounds in Birmingham, and Dr. John Kirkland, whose books every cardiac surgeon reads and now even reads, he actually told me whether I could examine the prosthetic valves by two-dimensional echocardiography, and I said yes, we could. And at that time I'd seen the color Doppler machine in Taiwan in a very secret sort of a meeting with one of the companies in Japan who were developing color Doppler. They were not sure they should develop color Doppler or not, because that means a lot of investment, a lot of monetary investment. But I thought it was great to see the flow, blood flow in the heart. And so there are others like Dr. James Somerville, under whom I trained at the National Heart Hospital and Institute of Cardiology in London, sure not that excited, but somehow that they must have, I'm sure they asked other people also, but finally they decided to manufacture and told me. And Rochester did not have that much money to buy a color Doppler machine. So when Dr. John Kirkland, who was kind of the chief at the University of Alabama, asked me what it will take me to move from Rochester to Birmingham, I just thought quickly in my mind and said, well, if I ask for 2 color Doppler machines, maybe I'll agree to 1. I said, if you can give me 2 color Doppler machines, they're very expensive, I'll come to Birmingham. He said, done. So that's how it happened. And then when I went home, my wife asked, what about the salary? I said, I was so excited, I forgot all about asking about my salary. Okay. But luckily that turned out to be better than in Rochester, so that didn't turn out to be a problem. But for a while, my wife was very worried that with the 2 or 3 little kids, we had 3 little kids, that how we're going to survive in Birmingham just on color Doppler without any salary.
Dr. Nanda, you have many firsts in echo. You were the first to visualize the pulmonary valve, first to diagnose bicuspid aortic valve. But I'm intrigued, you thought of stress echocardiography way before it became run-of-the-mill. What made you think of stress echocardiography?
Well, actually, when I was in Rochester, we were actually doing a lot of stress testing, and we found that it was not very sensitive to detect coronary artery disease, the sensitivity being in the range of about 60%. So we thought we really have to take some other technique, and radionuclide techniques were being used at that time. So we decided, why not we actually do a stress echocardiography, treadmill exercise echocardiography with echo. So that way we'll be able to not only look at the changes in the electrocardiogram, but also look at wall motion abnormalities. And it turned out that one of the fellow with whom I was going to work with, he was actually from Austria, and he was a sumo wrestler. So it was very convenient because when we, first of all, the chief of cardiology said that this is something he doesn't understand, doesn't think is very good. So he is not going to let anyone do his patients, but unless you yourself went and brought the patient. Now, being a sumo wrestler, very big and tall, he would actually wheel down the patients, bring them, and then when they were on the treadmill, the moment they reached the target heart rate or they could not do any further, and I was sitting with the transducer with echo machine, he would lift this patient, bring them on the bed, and immediately I could do that within a minute or so. I could look at the views that we needed. That's how it was born, and even now, I think we need to immediately look at the views as soon as the exercise is completed, but that made it very, very convenient. That's how stress echocardiography, treadmill stress echocardiography as it is done now, was born somewhere about I think we published the paper in 84, 85. We never thought it'll take off, but then over the years, it took off very well. When I went to Birmingham, they told me that they hadn't heard of stress echocardiography. Of course, we were developing color Doppler machines, so they would not even permit me to have a treadmill in the echocardiography budget. Finally, one of the company representatives donated his old treadmill, which was not working very well, which he used home for exercising himself. He brought it to the echo lab, donated, and that's how we started stress echocardiography in Birmingham.
Okay. You have worked alongside the great Professor Dr. Kirkland, a surgeon. What are your thoughts? Because I think to become a complete echocardiographer, the collaboration between the echocardiographer and the surgeon is extremely important. Yeah. But sometimes I feel is lacking in today's practice. Yeah. What are your thoughts on that?
No, I think that's very, very important. Of course, in the beginning, the reason we actually collaborated with Dr. John Kirkland, because whatever we did with color Doppler, we wanted to make sure that we are right. We diagnosed, for example, severe mitral regurgitation, or we saw a tumor on the mitral valve or in the left ventricle by echo, and then we wanted to make sure that we are correct. So surgery provided us the validation for many of the things that we do now with color Doppler echocardiography. At the same time, actually the surgeons, when they look at the heart is devoid of blood. So it's like a flaccid heart. They don't see the heart in motion like we all see with echocardiography. So it's very difficult for them to find defects or to even get an idea of the size of the, like for example, an atrial septal defect. So that was something where we found that the surgeons were very, very keen that we show them in the beginning so they can get a good idea exactly, how many sutures to put or what the size was. And so therefore, echo is very, very important in during cardiac surgery. And we used to do a lot, and now of course the anesthesiologists have been trained quite well, so we don't have to spend that much time in the operating room, and they're able to do a lot of things like monitor left ventricular function before and after surgery, and also help in valvular heart disease. What we now help actually, in addition to cardiac surgery, now as you know, many of the interventions, structural heart interventions, are done in cardiac catheterization laboratory. So we actually now spend quite a bit of time in the cardiac catheterization laboratory or hybrid laboratory, where you have cardiac surgeons and interventional cardiologists working together. And echo is an essential component of any structural, abnormality that needs to be corrected in cardiac catheterization or in cardiac surgery. It's an essential component of that, of that procedure.
I'm going to ask you a funny question. In all the subspecialties of echo, I want one answer. Which is your true love? Adult, ischemic, valvular, congenital, transesophageal, stress echo? One answer.
One is a stress echocardiography.
Stress echo, okay. And why is that, sir?
Because I think coronary artery disease is so rampant now, and one of the things that you can diagnose very easily or get some idea about prognosis or even diagnosis in the emergency room sometimes, stress echocardiography becomes very, very important. No radiation also.
Transesophageal echo. Again, you were a pioneer in this field. Do you feel that it's underutilized, and in the US or in India now it's increased? Do you all routinely have it in the OR room?
Yeah, it's routinely there. In any cardiac surgery which we do, transesophageal probe is routinely there. Even in many non-cardiac surgery, like for example cirrhosis of liver and all, they would actually have the transesophageal echo on board just to monitor left ventricular function, if nothing else. Yeah, sure.
There has been an explosion of new techniques in echo over the years. After color Doppler, we've had tissue Doppler, and now the latest new kid on the block is speckle tracking. What are your thoughts? What do you think? Is there a future in this technology?
No, I think there's definitely a future because what it does, it complements actually right now measurement of ejection fraction or LV function by two-dimensional echocardiography because you're able to look at small groups of pixels and how they move in, how they actually move into the heart and during the cardiac cycle. So I think that is it may in future, some people feel in future it may even replace ejection fraction. I'm not sure we are at that point right now, but at least it's a very good complements a lot. For example, patients who have cancer and who are on anti-cancer medications, many of those patients actually develop cardiac toxicity, that these drugs are cardiac toxic. And by the time the ejection fraction goes down, some of that toxicity, the cardiomyopathy or the dysfunction that develops may be reversible. So there actually the speckle tracking has become very useful because you can detect any very early cardiac toxicity before the ejection fraction go down. So I think there are some one or two very good applications. The other application, you can detect subclinical heart disease, for example, in patients with diabetes, hypertension, much better sometimes than with the echocardiography. So there is a role, already there's a very good role for speckle tracking echocardiography, and I think it's going to increase in the future.
Another interesting advance has been the use of LV opacification using these micro-engineered bubbles.
Right.
Do you all use this a lot in the US or is it just taking off or what exactly?
No, actually it's being used a lot in the United States. Before it was not being used that much because as you know in USA practically everyone is insured. So the insurance companies would not reimburse for the cost of this contrast echo as we call it. But now the insurance companies are reimbursing. And if you do not see two segments, there are about 17, 18 segments of the left ventricle. If two contiguous segments are not visualized by transthoracic echocardiography, that's an indication to use contrast echocardiography. And that has helped a lot because it's the same thing like doing a non-invasive angiogram. You can opacify the endocardium, the left ventricular cavity, and get a very good idea about the function of the heart. So that's has taken off a lot in the United States. Yeah.
Another modality I want to come to is this three-dimensional echo.
Right.
I know a lot of machines have this, but for some reason, at least in India, I see that not many doctors are well versed with this and do not utilize it in their day-to-day practice. Is it the same in the US, and what do you feel are the barriers to its global utilization as it were?
It's underutilized all over, including in the United States. One of the barriers is mindset. The mindset has to change. We are so much used, for example, looking at the mitral valve, we see two lines moving and we call it the mitral valve. But if you ask an anatomist, surgeon or pathologist, how does the mitral valve look? It doesn't look like that. So, but we are so used to looking at it. So now to change it back to something which really looks anatomical or looks pathological becomes very difficult in the mindset of all the echocardiographers. So there's a mindset problem, and I think that's being overcome slowly, but it will take some time. What has actually been overcome to a large extent in the United States is using three-dimensional echocardiography, and that's with three-dimensional transesophageal echocardiography in surgery, during surgery, and also during structural interventions in the cardiac catheterization laboratory or in the hybrid labs. But there is still underutilized as far as transthoracic echocardiography is concerned, but I think we are getting there and more people are using it. Also the reason was that it took a long time to do a three-dimensional echocardiography. Now you can use the same probe to do actually a two-dimensional echocardiogram as well as three-dimensional echocardiogram. So now it's much easier and quicker. So that was another barrier, was the time component.
I'm going to take time off from echo. I'm going to have a rapid buzzer round, and I want quick answers, no thinking. If you did not become a doctor, what would you have been?
A historian.
Historian. If not echocardiography, what subspecialty of medicine?
Probably electrophysiology or clinical cardiologist.
Your one favorite hobby?
Stamp collecting.
Philately. Oh, yeah. Very good. Your favorite type of music?
Indian music.
But pop or classical? Film song, old Hindi film songs?
Old Hindi film songs, yes.
Your favorite movie of all time?
That's hard to tell actually. Trying to think.
Okay, you can say two.
Okay, one would be maybe Lagan, I think. Lagan, and another maybe Sarkar. I think of these two. Yeah.
Your favorite city in the whole world?
San Diego, California.
Is it because of the food?
Yeah, well, and next is Mumbai.
Mumbai.
Very close.
Your favorite restaurant?
Usually we go to Mexican and Italian.
And your favorite cuisine is the same?
Yeah, from Mexican, Italian.
And your favorite novel, which you read 10 times?
Oh, I think it's Gandhi's autobiography.
Oh, fantastic. Before we end this thing, I would ask you a few more questions. What do you feel are the major lacunae in current day technology of echo?
Well, the current lacune is already been there, that we cannot actually look at the whole extent of the coronary arteries. So we can't look at that, those. And also actually that is the main one. And the other one is that some patients, the echo have very poor windows because they're very big patients, or they have lung problems, so that's the problem. Some of that has been overcome by contrast echocardiography, but I think coronary artery should really be seen by echocardiography very well because they are on the surface of the heart, but they're too near the probe, so we can't see them. But I think the technology is being developed so that we can look at the coronary arteries also.
Another exciting new aspect of echo is handheld echo. How impressed are you with the technology, or what do you feel is the future of handheld echocardiography?
No, I think it really has a great future because you can take the probe, keep it in your pocket, white coat pocket. Anytime you're in the emergency room or in the CCU, someone comes in with a short of breath, you don't know what's going on. You can actually do an echocardiogram on that patient and decide immediately whether he is having cardiac tamponade, he's having cardiac dissection, or he having poor function. It's very, very useful. Not only that, you can go to rural areas, so you don't have to transport huge machines to the rural areas, and you can take these small machines and make very quick diagnosis. So I think it's very, very useful. The probes are, if you take the one which is something like a cell phone, like the cell phone that you have, iPhone, then the quality is not so good. But if you take one which is something like the size of a small laptop, then the quality is much better. So you can use either of them. And also, it has gone to a stage now that it's not just a cardiologist or some internist or special interest in echocardiography using it. Now, practically every physician would be using it in the future. And these small probes, small echo machines, will be used by all. The other day, I had someone who was actually a gastroenterologist come down to me and try to learn echocardiography using the small probe. So it is going to be something, it's just mushroom, that whole field, Yeah.
So if you had a crystal ball, what do you feel are going to be the major advantages in machines and technology in the future, according to you?
I think there are going to be more of artificial intelligence would be introduced, has been introduced already in echocardiography, but that's going to be more and more, so that when you look at an echocardiogram, machine will be thinking very similar to what you are thinking. It may not be exactly the same. So that will make our work much easier, quicker, so that we would be able to actually, deliver very good care for the patient at the same time in a timely manner.
And finally, what does the future hold for Professor Nanda?
Well,
will you ever stop working, or are you going to go on teaching and spreading echo, the message of echo, all over the world?
Well, I right now don't have any other interest except echocardiography, so that's what I'll keep on doing. Teaching, doing echocardiograms, and clinical examinations like I do now even, and also teaching and spreading and going and lecturing, and I think I'll keep on doing that till the very end.
Thank you, Professor Nanda. It has been a most informative and a beautiful session with Professor Nanda on the past, present and future of echo. Thank you once again, CSI TV 2018.
Thank you, Robin. It's a great pleasure. I'm so excited that I'm meeting you and having a good chat with you here. It's really great.
The pleasure was mine.
Right. I have very fond memories of you and your father.
Thank you. Thank you, sir.